Hello. So my presentation is developing an individualized health plan for asthma. So the learning objectives for today is that by the end of the presentation, the learner will be able to describe signs and symptoms of asthma in school-age children, verbalize management strategies and new evidence-based practice guidelines for asthma, and give examples of goals for asthma management in the school setting. An overview of this presentation will be going over a case example, reviewing general pathophysiology and symptomatology of asthma, going over asthma management and evidence-based practice guidelines. I'll be sharing resources for asthma management in Pittsburgh, and we'll be going through an example of an IHP. So the case reads as follows. BH is a 12-year-old male presenting to the nurse's office with a wheeze, increased work of breathing, tachypnea, and a known history of asthma. He was sent to the school nurse during outdoor recess, during which he was playing soccer with his friends. Currently, it is winter, and his asthma triggers are exercise and cold air. He denies using a puff of his albuterol inhaler before going to recess. The school nurse obtains his vitals, his heart rate 130, respiratory rate 32, blood pressure 120 over 78, and temp of 37.3. He also has SATs of 88% on room air. She notes that the patient is in respiratory distress, demonstrates accessory muscle use, nasal flaring, and has an audible wheeze. Upon physical exam, he has an inspiratory and expiratory wheezes bilaterally. Cap refill is less than 2 seconds, and he has normal heart rate and rhythm with no murmurs or extra heart sounds. His skin is warm and pink. Past medical history is pertinent for the atopic triad, which is asthma, eczema, and allergic rhinitis. For his asthma, he's taking albuterol and as his rescue inhaler and Flovent as his controller medication. He's also prescribed Xyzal for allergies, which he takes in the springtime and around animals. He's also prescribed hydrocortisone cream for his eczema. Family medical history is rather non-contributory. His mother has seasonal allergies and GERD. His father has a history of a herniated disc and no other health problems. BH is of Chinese American descent, and his parents immigrated from China to the US before he was born. Their family identifies as agnostic and they do not follow any religious practices. So what generally is asthma? It's one of the most prevalent chronic diseases in childhood. Etiology is a combination of many factors, including genetics and environmental exposure. Basically, what happens is that it's a hypersensitivity response, usually to some sort of allergen, that leads to airway resistance and obstruction. So basically, the bronchioles are hypersensitive, leading to airway inflammation, inflammatory cell infiltration, increased mucus production, and smooth muscle contraction. Over time, it can lead to irreversible changes such as basement membrane thickening, collagen deposition, epithelial desquamation, and smooth muscle hypertrophy and hyperplasia. So on the right here is a diagram that shows what a normal airway looks like. And as you can see here, the asthmatic airway is constricted. There's less room here for air to flow, showing resistance. And then there's mucus here blocking the airway as well. So asthma is diagnosed based on a clinical picture and occasionally using results of spirometry. Um, so a history of intermittent or chronic symptoms that are consistent with asthma strongly points to a diagnosis along with wheezing upon physical exam. And then it's demonstrated by a demonstration of expiratory airflow limitation on spirometry. So the FEV1, which is the forced expiratory volume in 1 second, to FVC ratio, which is the forced vital capacity, is reduced, which shows that there's airflow obstruction, meaning that there's less air coming out of the lungs than normal. For children with a normal spirometry result or children who cannot reliably perform spirometry, usually kids under age 5, a trial of asthma medication is warranted to help make a diagnosis. This means that kids are usually sent home with a short-acting bronchodilator such as albuterol, and then if that medication helps with their symptoms, then usually it's indicative of asthma diagnosis. Then asthma can be categorized as mild, intermittent, mild persistent, moderate persistent, and severe persistent. On the right here is a demonstration of what spirometry looks like. So the kiddo's nose is usually clamped, and then they're told to take a deep breath in and blast the air out as fast as possible, and the machine will record a graph of the child's airflow. A medical management of asthma uses a stepwise method in which treatment potency is increased or decreased based on the severity of the asthma. The recommended long-term controller medications are different for children under the age of 12 compared to those older than age 12. A medication with short-acting onset, typically a short-acting beta agonist or low-dose glucocorticoid for Motorol inhaler, is prescribed for prompt relief of asthma symptoms. In mild persistent asthma, a low-dose inhaled glucocorticoid is added. In moderate persistent asthma, a low-dose inhaled glucocorticoid and long-acting beta agonist is used as a controller medication. For severe persistent asthma, medium or high-dose inhaled glucocorticoids are used in addition to a long-acting beta agonist. So you can see here that Management is shown in this step formation. So it says here um, that if a child is still having asthma exacerbations on their current medication, you first make sure that having proper inhaler technique. This means using a spacer, that there's no environmental factors that are triggering their symptoms, and that there's nothing else that's responsible for the symptoms. And if those can be ruled out, you would step up their medication. Um, Okay, so what does new evidence-based practice show about asthma treatment? One new management strategy is called single inhaler maintenance and reliever therapy, also known as SMART therapy. So, in pediatric patients over 12 years old, new evidence suggests that SMART therapy may help to increase asthma control. Basically, what SMART therapy is a combination inhaler of an inhaled corticoid steroid and a long-acting beta agonist for both the controller and short-acting relief. Smart inhalers have been shown to reduce the risk of asthma attacks and ED admissions, improve lung function, and decrease the need for reliever therapy. Another evidence-based practice management strategy is a school-based asthma management program. So these programs have proven to help increase self-efficacy and knowledge in children and have helped parents learn how to better recognize and treat the needs of their children. These programs consist of nurse-led lessons to educate children and parents about asthma triggers, medication, and inhaler techniques. They help parents and nurses formulate asthma management plans. They help nurses teach peak flow meter use, and they help nurses set goals for the children. So Easy Breathing for Schools was one of these programs that was designed according to feedback from parents, school nurses, and clinicians. And over 2 years, this program demonstrated decreased asthma-related absentee rates by 25%. In the city of Pittsburgh, there are plenty of excellent resources to refer to patients with asthma. The Children's Hospital of Pittsburgh offers a pediatric asthma center that offers services such as educational programs, community outreach programs, community screenings, and clinical research studies. They also provide assessments and education sessions for community schools and organizations. Um, Another wonderful resource for children is Breathe PA, in which certified asthma educators provide education training and resources in homes, schools, and communities. And lastly, Nationwide Children's Hospital provides a virtual asthma booklet, which provides great information on asthma flare-ups, triggers, and medications. They also include information on how to develop asthma action plans, which is what's shown on the right here, and to provide an asthma symptoms diary where children can record their symptoms and help providers to just see how their asthma is being controlled. Okay, so an example of an individualized health plan goal for children with asthma, based on this case, the first goal is that BH will be able to self-carry his albuterol and use it before recess 85% of the days by the end of the semester. So in the state of Pennsylvania, children with the provider's approval can self-carry and self-administer their medications. Since BH is 11 years old, he's developmentally appropriate to take control of his medication use. And it will help him because he doesn't have to go to the school nurse every time he needs to use his albuterol. Um, so in order to do this, we must obtain a written order from the provider to allow BH to self-carry at school and then distribute the PCP note to all of his teachers, teach his teachers and other school personnel about the student's asthma and albuterol. And the expected outcome is that BH will identify and describe the responsibilities for self-carrying the medication. He'll demonstrate safe use of his albuterol, and he will be able to identify his triggers and remember to use inhalers before exposure to these triggers. A second goal is that BH will be able to demonstrate proper spacer technique each time he uses his albuterol by the end of the semester. So asthma inhalers, such as albuterol, they shoot out at around like 60 miles per hour. And usually the medication just ends up hitting the back of the throat and it's swallowed. So spacers help to slow down the flow of the medication. They've been shown to be more effective. So to do this, we will educate the student and the family about proper and effective spacer technique, and then we'll educate the student and his family about the importance of spacer use and efficacy. And the outcome we expect is that the student will be able to demonstrate correct spacer technique, and he will be able to identify one reason why it's important to use the spacer with his inhaler. The last goal we have for BH is that over the semester, the number of early dismissals from school due to asthma exacerbations will be less than once a month. So asthma is a very prevalent cause of school absenteeism for children because of asthma exacerbations. They miss a lot of school and it ends up having long-term effects such as decreased academic performance, and it even affects them into adulthood as it's been shown that chronic absenteeism also decreases the rate of which children go to further education and have job stability. So it's important to educate the student and family about the characteristics of good control of asthma. So what does controlled asthma look like? And then we'll set specific goals of asthma control with the student and his parents and develop an asthma action plan with his parents and the healthcare provider. And the outcome we're looking for is that he will notify the school nurse and his parents when he's not meeting his goals for asthma control, and the student will periodically review with the school nurse and his parents to check on the effectiveness of his asthma management. Um, and in the case of emergency, um, asthma emergencies look like extreme cough, wheeze, chest tightness, shortness of breath, difficulty walking, talking, cyanosis, peak flow meter reading less than 50% of the child's personal best, and no symptom relief from albuterol. So in this case, the school nurse will administer 4 puffs of albuterol every 4 minutes until the ambulance arrives. It's important to make an emergency plan with the parents as well. And there's something called an asthma disaster preparedness kit, which happens in the case like of an emergency evacuation. You can grab the kit, and inside usually there's a reliever medication, a copy of the child's asthma action plan, a spacer, and other materials that they'll need. So here are my references. Thank you for watching my presentation.